Here I am presenting a case of paraclinoid aneurysm treated with surgical clipping. A 45-year-old lady presented to us with history of sudden right side weakness before a week, which was recovered spontaneously. The weakness was due to small left gangliocapsular bleed. Here is the cerebral digital subtraction angiogram showing complete supraclinoid occlusion of left internal carotid artery with changes of Moya-Moya disease and incidentally found large right paraclinoid aneurysm. As you can see, the right ICA provides collateral flow in left side brain, explaining the cause of aneurysm formation due to high flow circulation in right ICA. Do not mistake this as an aneurysm, this is a turn of PCOM. Aneurysm is hidden here behind the ICA. You can see the aneurysm clearly in lateral view. As a hybrid neurosurgeon, I can manage this aneurysm by endovascular as well as open techniques. Let me discuss some reasons making clipping is the choice for this patient. The structure to be managed is outlined here. Note that the neck of aneurysm is significantly wide. While dealing with aneurysm, internal carotid must not be compromised at any cost because it is supplying both the lobes of brain. That's why coiling is very risky option because coil may dislocate from sac due to wide neck and may block the internal carotid. In flow diversion, there is potential risk of side branch occlusion, which may lead to blind eye due to ophthalmic artery occlusion and visual field deficit due to dominant PCOM occlusion. Surgical clipping becomes ideal here because it can occlude aneurysm without affecting ICA, ophthalmic, or PCOM artery. Now I am going to demonstrate the surgery. This is the microscopic view of right frontotemporal lobe and the sylvian veins. The sylvian fissure was dissected and opened to gain wide space around carotid artery. The internal carotid is now exposed. You can see the dominant large PCOM here. Still, the aneurysm is not in view. The aneurysm is hidden here behind the anterior clinoid process, requiring ACE removal. Drilling and removal of anterior clinoid process was performed with extradural approach. The base of clinoid process was thinned out with drilling and then fractured with dissector. The anterior clinoid process now removed totally in fragments. Now I am switching to intradural view. The dura near superior dural ring is partially dissected with sharp cuts. As you can see, the proximal part of aneurysm neck is now easily approachable. See the cherry red color of the dome of aneurysm, which is due to thinned out wall. A curved clip is applied at the neck of aneurysm. Note that proximal control is taken in the neck in this patient. See the tip of the clip visible medially to ICA, confirming total inclusion of neck of aneurysm. Dome of aneurysm is ruptured with needle to decompress and confirming total occlusion. This is the surgical overview at the end of surgery. The surgery was completed without any complications. The patient was having no neurodeficit. This is the video after 2 weeks of surgery. The extraocular movements and vision is normal after surgery. This is the scar at the time of suture removal. We do not remove hairs in females. Thank you for watching.